if, sorry, ah, skipping ahead. Let me pull up my little drawing thing here. Okay, so remember that if I wanted to draw my draw here, my heart, okay, and I have my AV node, I have my SA node, and then I have my left and right bundles, right, and then Purkinje fibers. So if I have a sinus bradycardia that originates from the atria above the AV node, meaning that signal travels down, and I am in some form of bradycardia with this type of stimulus, remember, where does atropine work? Well, it works at the AV node primarily to remove the brakes. So it blocks parasympathetic signals at the vagus nerve. That's where it innervates the AV node. And that's going to help increase heart rate above from rhythms that originate above that point, and or even at that junction. But if I have a rhythm that's originating down here, like a wide complex ventricular type of bradycardia, or a rhythm that's originating down here because I have a total blockade of my AV node, atropine is not going to have a ton of effect. So does that mean we just never give it to those patients? That's not necessarily true. If if you suspect a wide complex or some type of AV block, and you're seeing symptomatic bradycardia, we can still consider that atropine, but other treatments, escalating to treatments like pacing and even an epinephrine drip or push, are going to be probably needed because that atropine is less likely to have an effect because of where it exerts its effect. So if we have significant shock or hemodynamic compromise in these symptomatic bradycardia patients, we are going to go straight to transcutaneous pacing. I know that's a kind of new term because we haven't covered it, but you guys are going to be covering that skill in depth. So you will be very adept at how to initiate transcutaneous pacing. So don't worry about that in this lecture. We're not going over the steps of doing that, but that is going to be your next step in those severely hemodynamically compromised patients. And what I mean by that is, hypotension, altered mental status, peri-arrest. We need to get pacing on board right away because it's atropine is, we shouldn't delay pacing to give atropine. And if, let's say, they remain hypotensive and we're still concerned about shock, we can give a push dose of epinephrine. Sorry, my little arrow didn't quite draw right, but we can give a push dose of epinephrine. We should also be giving fluids to these patients. And that push dose, remember our IV push dose is that 10 to 20 mics. And we could also start an IV drip of epinephrine. And the reason we talk about Levophed is norepinephrine a lot as our primary go-to pressor in shock, other than hypovolemic shock and anaphylactic shock. But epinephrine in bradycardic situations is our go-to because norepinephrine or Levophed doesn't give us enough of that beta stimulus to really get the heart rate up. And we give epinephrine because we get all the alpha and beta support, and we can improve cardiac output a little better with the epinephrine. So epinephrine is definitely preferred in this situation. Okay, so moving from slow, narrow atrial rhythms to now fast, narrow, regular atrial rhythms. So sinus tachycardia just means we've met the same rules. I have a P wave for every QRS complex. I have regular R to R intervals, okay? And my QRS complex is less than 0.12. So I have regular P waves, narrow, and fast. That's sinus tachycardia, right? Can't be anything else. So in sinus tachycardia, now we have to think about what causes sinus tachycardia. So let's think about some of the things that could be present. Sinus tachycardia could be most commonly it's a compensatory rhythm. And what does that mean? It means we're compensating for something, right? We naturally raise our heart rate when we have increased metabolic demand or increased oxygen demand. We need more blood flow to the tissues, we need more cardiac output, we increase our heart rate. So sinus tachycardia can be a normal variance in, when we're exerting ourselves. Or it could be a sign of compensation for hypovolemia, so low fluid volume status, anemia or like blood loss, or chronic blood loss, or even like poor red blood cell production. We could also see things like neurogenic, so anxiety. But again, anxiety, I want to really hit home the point that anxiety is a symptom. It's not necessarily its own disease. People can have anxiety disorder, which anxiety is a symptom of, but oftentimes anxiety is telling you something else is going on. And so we could have things like hyperthyroidism. We could have things like neuroleptic malignant syndrome. We can have all of those things that can cause tachycardia with anxiety. Another very common or ominous cause of tachycardias is pulmonary embolisms. And so that should be on your differential when you see a fast rhythm is I need to assess this patient for signs and symptoms of a pulmonary embolus, because unexplained tachycardia with like shortness of breath or pinpoint chest pain could be a sign of a pulmonary embolus. Again, most types of shock other than neurogenic causes have tachycardia as a symptom. So we need to make sure we're ruling out any causes of shock. And then big one is fever. If we've all been sick and had a fever, and if you ever checked your heart rate, it's probably up in like the 118, 110, 120 range. And that's because, again, to raise that fever, what do we have to do? We have to increase our metabolic rate. And that increased metabolic demand causes a compensatory tachycardia. So usually when we talk about rates with tachycardia, we're saying greater than 100, right? So our rate is greater than 100. But when we start to see rates greater than 150, this should be raising alarm bells that we are seeing potentially a non-compensatory tachycardia, or a tachycardia that's caused a cardiogenic source, or like a true dysrhythmia. Now, does that mean that a rate over 150 rules out any other underlying cause like hypovolemia or sepsis or fever, infection, or hyperthyroidism? Absolutely not. You can definitely have compensatory rhythms greater than 150. However, when you see that rate over 150, that should be our little red flag that we see potential for AV nodal reentry tachycardia, or is it AFib with rapid ventricular response, or some type of dysrhythmia that may require treatment from us. So in tachycardias, our treatment pathways are going to be a little bit different. We have, once we've ruled out all those other causes like hypovolemia and hyperthyroidism and all these other things that could lead to sinus tachycardia, we have to think about those pure cardiovascular causes. And when we see a pure cardiovascular cause, we should be ready to jump in and treat those rhythms, because we can't sustain rhythms greater than 150 for long periods of time. Once we get that heart rate up into that upper limit, and our upper limit is 220 minus RH. So here is that little formula. And so you can calculate your max heart rate by this simple little formula. And once we start seeing rates up towards that upper limit, we are in a state where we could, again, remember, have that really poor filling. Because if I have such a fast heart rate, my heart cannot fully expand. So it is a type of what we call restrictive cardiomyopathy, because the heart rate is so fast that we don't have time during that cardiac cycle to get adequate filling. So we start to see decreased filling of the heart. And that's problematic, right? We need blood to have cardiac output. So in addition to that, the muscle is working a lot harder. It has increased oxygen demand, and it can increase the risk of myocardial ischemia. So all of those things are bad. And so because of that, we treat tachycardias that are symptomatic when we don't have other causes, right? And again, here's another list of causes just to expand upon what we just talked about. Let's see, what is our treatment? So again, first question to ask, is there an underlying cause? And I'm going to tell you, for testing purposes, be ready to have critical thinking skills to rule out, is this tachycardia compensatory tachycardia, or is this a rhythm I need to treat with cardiac medications or procedures like cardioversion, which we're going to talk about. So sinus tachycardia, like I said, most commonly compensatory. But when it's not compensatory, like it's in the setting of some sort of AV nodal reentry tachycardia, or a new onset of AFib with rapid ventricular response, or aflutter, or things that can have a really unsustainable heart rate, and the patient may be hypotensive or have chest pain or weakness or things like that, we need to intervene. And so in narrow complex tachycardias, meaning less than 120 milliseconds or 0.12 seconds, we are going to treat that with a couple different mechanisms. The first mechanism we use is called vagal maneuvers. And we're going to cover how to do modified Valsalva. And you will see vagal maneuvers is a basic life support technique, and it is so effective that it has conversion rates just as good as adenosine or diltiazem in converting these rhythms to a narrow rhythm. However, sometimes they don't convert, and sometimes we need to treat with medications. And so I want to just touch real quick before I go forward that this little tidbit right here, sinus tachycardia accompanied by an MI, should be maybe rate control with beta blockers. Debatable evidence on that now. This is just included. This was old from honestly last year, but reading up on this changes in this over time is that beta blockers may increase mortality when there's potential damage to the heart muscle. So we may actually want to avoid that. So kind of ignore that slide for now. But again, the medications that we're going to use to treat these narrow complex rhythms are going to be adenosine and diltiazem or verapamil. Those are our primary go-tos in narrow complex tachycardias. And when we talk about narrow complex tachycardias and treating them with medications, we usually use medications when the blood pressure is stable, but the patient does have symptoms, like they're having palpitations, they're a little dizzy, they're pale, having some shortness of breath, but their blood pressure is stable, they're not in shock. That's going to be adenosine or diltiazem. Primary go-to is going to be adenosine for our regular rhythms, meaning our R to R is regular. Diltiazem, we can use it in regular R to R rhythms, or we can use it in atrial fibrillation with rapid ventricular response, is probably more common in most protocols. Okay, so moving on to sinus rhythms that are a little different. So we have sinus arrest. So sinus arrest can be something called a sinus pause or sinus arrest. This is basically where we have a pause or a little period where we have no beats. So we see a regular sinus rhythm, and then we have a sinus pause. And this can be a cause of sinus bradycardia, because if I were to count up, average out my rate here over all of this strip, it's going to be less than 100. So because of that pause. So I'm going to end up with a bradycardic rhythm. So generally these are asymptomatic, but if they are symptomatic, we can treat with atropine. And if they're so symptomatic, right, that they are like in peri-arrest shock, which would be incredibly rare for this type of rhythm, we could potentially pace this patient. And causes something called sick sinus syndrome, which is basically a problem in the SA node. Hypokalemia, low magnesium could cause this. Sleep apnea it could be a cause of sinus arrest, and potentially myocardial infarctions. MIs can cause all types of different dysrhythmias depending on what area of the heart is ischemic, because that's going to affect different parts of the conduction system. So one of those things we talked about is that causes that sinus pause or sinus arrest is called sick sinus syndrome. And sick sinus syndrome is where, like I said, sinoatrial nodal dysfunction. And it takes, some special diagnostics, usually like sending someone home on a Holter monitor to diagnose it, to record it and capture this. But essentially it's caused by progressive fibrotic changes in the SA node. And symptoms of it could be poor exercise tolerance, like you can't up your heart rate when you need to, fatigue, dizziness, headaches, nausea, episodes of palpitation where you're getting like ectopic beats from other parts of the atria. You could have chest pain and shortness of breath. And usually you see sinus bradycardia because we're seeing regular sinus pauses, and patients can go into AFib or A-flutter, and it could be significant enough to where they may need a placed pacemaker under the skin. They also may need to take medications like to prevent blood clots, so our like Coumadin or factor 10 inhibitors, or it could be also atropine to keep lower the parasympathetic dysfunction. Something called dysautonomia could lead to sick sinus syndrome as well. And certain viral infections like COVID, we've heard about long COVID. This could be one of the diagnoses associated with that. Okay. One of the most common arrhythmias, and then probably everybody, if we take a paramedic class and put everybody on the monitor, we can probably find 2 or 3 people that have a sinus arrhythmia. And I know I have one, and it can feel a little weird sometimes. And if you have it, you've experienced this, but essentially sinus arrhythmias are caused by the normal respiratory cycle. It puts pressure on the heart as the diaphragm contracts, and that changes the conduction with respiration. So as you breathe in, it causes a vagal stimulus and it slows that heart rate down. And then as you exhale, increase or exhale, that changes that vagal stimulus, and we can see an increase in heart rate. And so with that respiratory cycle, you get this waxing and waning of the heart rate. And that can increase with age, decrease with age. It could also have to do with your distensibility and baroreceptor reflexes in your carotid arteries. So very common, does not need treatment, generally. All right, and this is something called a sinoatrial nodal exit block. This can often get misconstrued as maybe another type of heart block in the AV node, but a SA block, which are probably hard to diagnose, is basically intermittent dropped P waves. So you see here, if I were to draw like right here, this QRS complex, it has no P wave in front of it. You see all these P waves right here, and then here's a dropped P wave right here, right? There should be a P wave here, and that intermittent P wave is because there is a signal, like if here's my SA node and I'm trying to get to the AV node, right? The signal is blocked from actually leaving the SA nodal tissue, and that could be from fibrosis, it could be from all sorts of different causes. It can lead to sinus bradycardic rhythms, so slow rhythms. And again, if it's symptomatic, we can treat with atropine. Very uncommon to have to pace somebody with a SA block, but it's a type of rhythm that could exist causing bradycardia. Okay, so as we move on, we're going to talk about premature atrial contractions, multifocal atrial tachycardia, or wandering atrial pacemaker. SVT, PSVT, these rhythms, AVNRT, AFib, A-flutter, and AFib with RVR. So these are all our atrial arrhythmias. So we've talked about sinus arrhythmias and sinus nodal originating. Now we're going to talk about rhythms that originate from the atria, so above the AV node, but not from the SA node. Because remember, all of the heart muscle has automaticity, so rhythms can originate. All of a sudden, some cells within the heart can get irritability and take over driving the rhythm of the heart. And in atrial arrhythmias, we have a pacemaker coming from somewhere other than the SA node. Okay, the first atrial arrhythmia, and this is a very common one, is called premature atrial contractions, or PACs. And so these are abnormal atrial beats that occur outside of that normal cardiac cycle. So what it looks like is we call these ectopic beats. And if we look at this little chart on the right, you can see you have this sinus rhythm, and then you have this kind of funky looking, narrow, complex beat. And how do we know that it is originating from the atria? Well, two things. It's going to have a P wave, which you can see here, but it's an abnormal looking P wave that differs from the rest of the P waves. Why do you think it's abnormal compared to the P wave? And if we go back to that Einthoven's triangle thing, remember, in lead 2, and let's say I'm monitoring in lead 2, and my SA node is somewhere over here, and that positive depolarization signal is going towards the positive lead here, right? So that's going to create this upward deflection in the P wave. But let's say all of a sudden I have an ectopic beat somewhere right here, and it travels this way. That's going to create a different looking P wave, more of a negative deflection, because we're moving, in general, the primary vector is away from that lead. So if that happens, we're going to get more of a negative beat, right? So if we think about this, sorry, let me just fix my pen. Okay, I guess I can't. If I have a ectopic beat, or I have this funky beat, and I want to understand, is it atrial, right? We know it has a P wave, but then it's also going to be narrow. And that narrow, less than 120 milliseconds or 0.12 seconds, is going to tell me that I have an ectopic atrial beat. And this can be caused by irritability in the atria. It could be caused by fluid overloading, where we get lots of stretch in the atria. It could be caused from medications like sympathomimetics or stimulants, caffeine, alcohol intoxication, dehydration, electrolyte imbalances, all sorts of things, or it could just be totally benign. But it also could be a trigger of AFib. In patients that have PACs, oftentimes that could precipitate going into atrial fibrillation. The other thing that may occur is abnormal atrial contractions, because if they're frequent enough, the atria then can't fill properly or empty properly, because now we're having the atria start beating outside of its normal cycle. And when we have enough of these together, it can lead to blood clots. And this is why AFib is one of the major risks of atrial fibrillation, where we have this sustained irregularity in the atrial pacemaker that causes blood clots. And that's the primary cause of strokes, is actually AFib. So there are some terms that we use to describe PACs, like how many there are. And so if we have every third beat, for example, and this is a PAC. So if I'm going to pull up my little pen here. If every third beat, 1, 2, 3, is a PAC, we call that trigeminy. If every other beat is a PAC, so let's say I have right here, and then boom, I have one right here, this is called bigeminy. And this is going to occur for any type of ectopic beat, because we could have PVCs, or premature ventricular contractions, where we get ventricular beats outside of the normal cycle. So treatments of PACs, generally, if they're benign, we don't do anything. But if they're symptomatic, the patients may require surgical ablation, which is where they go in and cauterize that tissue where the pacemaker might be coming from. They may take beta blockers to try to control the rate. And they may need anticoagulants if it's so bad that they're going in and out of AFib constantly. And we want to treat that underlying cause. Like a big cause of atrial dysrhythmias is fluid overloading, and kidney failure causes that. And so patients that are in kidney failure often end up in AFib because they are retaining fluid, causing the atria to stretch. And as that atria stretches, it gets irritable, and that can create pacemakers cells to start firing off in different parts of the atria, or muscle cells to just depolarize and stimulate the cells next to them. So we get some abnormal stimulus. Okay, so that was PACs. Now we're going to look at something called multifocal atrial tachycardia. And this can be associated with lung disease, which is pretty interesting. And it's, again, something we call irregularly irregular. And what does that mean? Well, it means that we have irregularity in the R to Rs, but it's not at regularity. It doesn't have like a regular pattern to it. Like every third beat has this irregularity to it. It is consistently irregular. Multifocal atrial tachycardias generally are pretty fast. And essentially what it means is we have a narrow complex tachycardia with some differing PR intervals, and we have differing P wave morphologies. So we can have a P wave that might look vertical, we can have a P wave that's inverted, we can have a widened P wave, we could have a P wave that has a saddle hump in it, and all of those different P waves indicate we have a pacemaker coming from somewhere else. So we have an atrial beat coming from different parts of the atria. And so multifocal atrial tachycardia is basically we have different ectopic foci firing in the atrium. So varying R to R, varying P to R, we have at least 3 P wave morphologies, and nearly 60% of these patients that have this dysrhythmia have some type of COPD or pulmonary disease. It's commonly mistaken for AFib, but we're going to talk about AFib. AFib, there is no discernible P waves. And in atrial tachycardia, there is discernible P waves, and they just shift in morphology. If they're symptomatic, again, we could consider rate control medications. And we're going to talk about when we would consider electrical therapy or cardioversion. And that's going to be when someone is severely symptomatic with a very tachycardic rhythm, and we've ruled out other causes, and we may consider using electricity to treat those rhythms. And we'll talk more about that. Okay, next we're going to talk about supraventricular tachycardias, and these are tachycardias that originate above the ventricles, supraventricular. And we generally talk about SVTs as this thing that is actually mixed up with a type of rhythm called AV nodal reentry tachycardia. And we talked a little bit about that earlier. AV nodal reentry tachycardias is where we get a reentry pathway in the AV node that creates as kind of like a signal that can rapidly create depolarization of the AV nodal cells, and that causes propagating signals down to the ventricles very rapidly. So it's a narrow complex, very regular. Sometimes the P waves can be hidden, or sometimes they may not be present at all because it is so fast, and that the focal origin is actually coming from the AV node itself in this sort of focus loop. There are other types of these narrow SVT rhythms that are not necessarily AV nodal reentry tachycardias. They could be AVRT, which is the remember the WPW or accessory pathway between the atria and the ventricle that doesn't have that brake pedal on it. We can also get, if we see one key thing to note here is if we see a normal P wave, QRS complex T, and it's just really fast, but we have this nice QRST, and we see these normal P wave, and before each QRS complex. And even though we have this fast rate greater than 150, anytime we see that normal looking QRS complex, we should consider this a sinus tachycardia and really rule out a compensatory cause. But when we're going to look at some SVTs or AVNRTs, they generally look funky. They have this appearance where the P wave is like hidden, maybe buried in the T wave, or retrograde. We call that P waves, because the P wave is actually kind of firing, but inconsistently compared to the AV node. And what we want to think about is, first of all, if it's less than 150, we shouldn't be considering this an SVT or AVNRT or AVRT type of rhythm. And we're going to travel, when we see this rhythm, we're going to travel down these two different distinct pathways. Are they stable or unstable? Stable tachycardias, in this type of rhythm, we're going to treat with medications, adenosine, or even our calcium channel blockers. Our primary go-to is going to be adenosine. And before we do medications, we're going to try some vagal maneuvers, and then we're going to go to that medication step. If they're unstable, we're going to go down the pathway of what we call synchronized cardioversion. And synchronized cardioversion is delivering a synchronized electrical shock on the monitor that synchronizes the shock to the R wave. And we're going to definitely be going over this procedure in depth, so I'm not going to present on it in this lecture because you're going to get that in lab. But know that unstable narrow complex tachycardia that is not associated with a compensatory rhythm needs to get cardioversion. And these are again, to remind you of some of these big causes that could cause this compensatory tachycardia, and that's sepsis, infection, sympathomimetic drugs, hyperthermia, malignant hyperthermia, neuroleptic malignant syndrome, those agitated patients. All of these things could lead to compensatory type of tachycardia. Okay. When we talk about PSVT versus SVT, these are just, again, terms that we use to describe tachycardias above the ventricles. And in PSVT, it means paroxysmal. That just means it comes and goes and tends to have a rapid onset and then end abruptly. Sometimes AVNRTs, which are AV nodal reentry tachycardias, we often refer to them as SVT, can look like ventricular tachycardia. We're going to talk about why that is. They can have a widened appearance because technically the rhythm is originating in the AV node, not the SA node. So the QRS can widen slightly, but it's still above the ventricles, and we still treat it with our adenosine, verapamil, or electricity. And we're going to look at some of those rhythms on some slides, so we'll be able to identify that. So for these things, SVT or AV nodal reentry tachycardias or AVRT rhythms, they tend to have a very sudden onset. I was just sitting there doing my homework, and all of a sudden I started getting palpitations. Or, I was lifting weights and just suddenly got palpitations, and now they won't go away. And oftentimes it's because these AV nodal reentry pathways get triggered by irritability. Someone drinks some caffeine, they get dehydrated, they're under stress, they're working out, and it increases the cardiac or the myocardial excitability and stimulates that accessory pathway, and they end up in this feedback loop that they can't stop. So sinus tachycardia, our compensatory rhythm, right? That tends to have more variability and a progressive onset. So it's pretty normal that if you're running on a treadmill for your heart rate to slowly increase and increase and increase up, maybe even closer to that max heart rate, depending on your effort. And that is normal. And as you rest, it slowly comes down, right? Where AV nodal rhythms, like AV nodal reentry tachycardia, often referred to as SVT, tends to come on, boom, all of a sudden, and it stays up. Even with rest, it doesn't change because it's not compensatory again. So when you see a rhythm that has variability, like the rate is going up and down a little bit, the rate might change. It slows down with rest. It changes with position. That is probably a sinus tachycardia. Like I talked about before in the last slide, if you see a normal P wave and a normal QRS and the rate is just fast, that should tell you that you are looking at originating rhythms, where our other are the rhythms, narrow complex rhythms that we are concerned about treating with medications, are generally originating not from the SA node. Okay. The most common type of what we call SVT is that AV nodal reentry tachycardia. Has no P waves or what we call retrograde P waves. And we're going to look at that on the next couple slides. And like I said, they're usually some type of precipitating factor that causes what seems like a spontaneous onset. And it may even be just one PAC that falls out of line, and that triggers that reentry pathway. Okay. AV nodal reentry tachycardia is that most common cause of what we refer to as SVT. AV nodal reentry tachycardia is because there are two pathways in the AV node, and one is called a fast pathway and one is called a slow pathway. And basically what happens is when I have two lanes of traffic, let's say, I have like one lane of traffic going this way and I got a little car driving down this one, and it takes a while to get down the slow pathway. Okay. And then I have a fast pathway that allows a signal without brakes. So we get like a Ferrari race car that travels down here. So essentially what happens is this pathway depolarizes and repolarizes, and then this signal can jump and re-signal the fast pathway. And we get this bouncing back signal of where these different pathways are in their refractory and relative refractory period, and allows for this loop, or this signals to get stuck in this loop that causes very rapid propagation down the bundles and into the ventricles. And what's called in 80% of these AV NRTs, what we call a retrograde atrial depolarization, to where we get a signal traveling up this way, causing a retrograde P wave. And what a retrograde P wave is where I have my QRS complex, but in the T wave, I might see a little hiccup like that. And it's because the P wave, sometimes we refer to it as buried in the T wave, but it's actually what we call a retrograde, or a P wave that's happening because a signal is traveling up here and stimulating the atria. Okay, let's finally look at some examples of AV nodal reentry tachycardia, or oftentimes referred to incorrectly as SVT. And you'll hear me use these synonymously because it's ingrained in my brain, but this is what we see as AV nodal reentry tachycardia. So first of all, note the rate in the R to R, very consistent, very fast. We have almost 200 beats per minute here. It is very quick. So what do you notice about the QRS complexes? Do you see a P wave before the QRS? The answer is no. I don't see a consistent P wave at all, but I see a very consistent rhythm. And in this case, we can see if I start to look in lead 2, which is at the bottom and over here in the 12 lead, it's hard to see, but if I look, there are these little buried P waves in here. You can start to see them a little better here. These are retrograde P waves. This is classic AV nodal reentry tachycardia. And this patient is not going to get better necessarily without some intervention. Sometimes they can self-convert, but we may need to intervene with this patient in two ways. So we have stable or unstable, right over here. If this patient is stable, right, we're going to see BP normal. They may have palpitations, they may have symptoms, but they are stable. This is going to be meds. I'm going to put RX. Okay? Unstable, we go shock. And we shock using synchronized cardioversion, which we're going to go over that procedure. Okay, so here we can see, again, that buried P wave. This is zooming in, so we can see here in lead V1, we can see these little retrograde P waves. And these retrograde P waves are those not ectopic signals to the QRS, but they're abnormal signals to the atria from the AV node. And that's a signal of that pathway. Here's another example of AV nodal reentry tachycardias. Now you can't see the P waves here very well, but what you note is you see absent P waves before the QRS complex, a very fast rhythm. It's less than 120. And remember, there is some cases where this type of rhythm can have a slightly widened QRS, but it's generally not very pronounced. And then we have a regular R to R, and we are very fast. How fast are we here? Again, we're just over one big box, so very, very fast, 220-ish. Okay, so again, management, basics. So we have to ask, first, are they symptomatic and are they stable or unstable? So let's go down the stable pathway. So first thing we're going to do is vagal maneuver. Always, always, always vagal first. This is not just a testing thing. You can convert these rhythms with vagal maneuvers if you do them properly. And I've never been given adenosine, but I've given enough of it to know that I never want to ever have that medication administered. It's torture for your patient. Adenosine is basically stops the heart temporarily, and it causes that impending sense of doom and the feeling of dread and that of dying essentially for a couple seconds in your patient before their heart normal conduction kicks back in. It is very effective, but it is awful. So we should be, not wanting to just jump on administering it unless we have to. So vagal maneuvers are done by, but the most effective way is something called the modified Valsalva maneuver. And this is where usually a patient is lying on a gurney, and we have them blow into a syringe sitting up, and we have the head of the gurney all the way flat. So essentially, I'll draw a little picture. So our head of the gurney is flat, but our patient is sitting up like this, and their feet are out like that. And we're helping hold that patient up. And while they're sitting up, what we're going to do is have them blow into a syringe like they're trying to blow the plunger out for about 10 seconds. And they can blow on that syringe, blow, 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 blow. And then right at the end of that time, we're going to roll them onto their back and elevate their legs. And we're going to do that work for them. So we're holding their arms and we lower them down. We can practice that in lab. You can watch people's heart rates go from, normal to about 20 beats per minute. It dramatically causes a pretty dramatic vagal stimulus, and that can lower the heart rate. If that doesn't work, we're going to go to either adenosine or a calcium channel blocker. And again, I would say most commonly we see calcium channel blockers used in AFib with RVR, but there is plenty of evidence that shows using them in AV NRT works really well. And it's a lot more comfortable for the patient in terms of not having the horrible side effects of like the feeling of impending doom that adenosine can cause. But adenosine is still probably the most commonly used drug because it just works so rapidly, and it has very low side effect profile because it has such an incredibly short half-life, where calcium channel blockers are associated with like decreased cardiac output and all these some other less pleasant side effects that could occur. But there is the less of that immediate like terrible feeling with calcium channel blockers compared to adenosine. But our dosing for adenosine for the adult patient is 6 milligrams for the initial rapid IV push, and you need to give that an proximal IV, like an 18 gauge in the AC, for example. And we want to follow that up with a flush. One thing that I've learned is mixing up your flush and your dose like in the same syringe and just rapidly pushing that whole syringe, like in a 10 cc or 20 cc syringe with saline and your dose of 6 milligrams. Some services have gotten rid of the 6 milligram, have gone straight to a 12 milligram dose. It's like, why have to dose your patient with this horrible drug twice? If six, sometimes 6 is not enough and they need the higher dose because the half-life is so fast, it just does not actually reach the AV node. So some have gone to a 12, but what we teach is 6, 12, and 12. And that's kind of we don't give any more after that. So if we've given 6 and 12 and 12 or 12 and 12, whatever your dosing is, then we can go to the unstable algorithm if they're not converting out of that rhythm. And that's even if their blood pressure remains okay, we can consider going now down the cardioversion pathway. And the cardioversion pathway, like I said, we're going to go to if our stable treatments are not working for the stable patient, or if my patient is already just very unstable, like they have a low blood pressure, less than 90, they're altered, they're having like severe diaphoresis, very pale, anything that looks like, man, this patient's like getting sick fast, we should go right to that unstable pathway. And again, we could I put consider Valsalva here because it's just a consideration. But if the patient is really unstable, we're going right to shocking. And with synchronized cardioversion, remember we talked about it synchronizes the shock to the R wave. And in unsynchronized shock, or what we call defibrillation, the reason it's called defibrillation is we give it for ventricular fibrillation. There's only 2 instances we ever use unsynchronized shock, and that's in torsades and ventricular fibrillation. And torsades is a polymorphic VTAC that we would only time we don't push the sync button on the monitor is in those 2 indications. But for this case, we're going to do a synchronized cardioversion, and for narrow complex rhythms, we use 50 joules on the monitor, and for wide complex rhythms, we're going to go with right to 100 joules. And the other types of treatments are basically for patients, avoiding those known triggers if they have this condition. They may need to get what's called an ablation of any of those accessory pathways to treat this permanently. And until they can have that, they may have to avoid caffeine. They may have to avoid stimulants like pre-workouts. They may have to avoid getting dehydrated, stress, all those kinds of things can lead to triggering events. All right, we talked about AV NRT, which is where the AV node has an accessory fast pathway in it. And then we have AV RT. AV RTs are accessory pathways from the atria to the ventricle. And this can be caused by something what we call WPW, and WPW is Wolff-Parkinson's-White syndrome. And this is a very tricky dysrhythmia. It is rare, but if the patient does have a AVRT or AV nodal, AV atrioventricular reentry tachycardia, not an AV nodal reentry tachycardia, now the accessory pathway is here. It's between the atria and the ventricle. And there's 2 types. We have a pathway where we can go down through the AV node and up the accessory pathway and then re-stimulate the AV node. And that's called orthodromic. And then we can have antidromic, where we get this pathway that goes down, bypasses the AV node, and then retrograde stimulates the AV node this way, but then stimulates down this way. And that's called antidromic. Orthodromic, what we call anterograde conduction via the AV node, produces a regular narrow complex rhythm. And there's no bundle branch block. And sorry, I think that's supposed to say wider complex, because these are where we get these kind of what we classify as narrow complex tachycardias, but they're a little bit wider. In antidromic AVRT, anterior grade conduction is via the accessory pathway. And that accessory pathway between the atria and the ventricle, and this is caused by what's called WPW, this is what that disease is, can create a wider complex very fast, but still not a ventricular dysrhythmia. And it can make it difficult to distinct from the ventricular rhythm. So it's something you really want to just take a quick look at. It's often triggered by premature atrial beats. There are oftentimes irregularities in this, and it can look a little bit like irregular AFib. And so what we see most common is that orthodromic pathway, and it's triggered usually by, like we talked about, some sort of PAC. So there's a shortened PR interval. So we have a P wave, very fast rate with a slightly wider QRS. And this is the condition we call WPW. There's a very distinct type of appearance of what's called a delta wave on the QRS. And that QRS delta wave is a small like hiccup essentially in that upsloping part of the QRS. And in these patients, we can also trigger what's called AFib with RVR. So if we have a patient with WPW or an AVRT and they're having an irregular, very fast rhythm, we want to avoid at all cost any class 2 or class 4 medications. And you may think, wait a minute, adenosine is in the class 4 and I just learned to treat these types of rhythms with adenosine. Well, in this particular disease, adenosine can be a lethal combination because what does adenosine do? Well, it blocks the AV node, okay? And so the AV in this orthodromic condition, we can go back here and review that. In the orthodromic pathway, we get AV nodal path conduction and we have this accessory path. And so what happens is if I block the AV node completely, like nope, adenosine blocks that AV node, all I have is the accessory pathway. And so that can lead to what's called an ectopic or stimulus of the ventricular cells, and that can trigger the patient to go into ventricular fibrillation and make them code. So anytime we see an irregular, sort of wide, very fast rhythm that we associate with a WPW, we have to use extreme caution in giving adenosine. There are other medications. We can use amiodarone actually in these patients. We can also use lidocaine in these patients. And we want to prioritize those vagal maneuvers. And we may just go right to cardioversion with these patients because it is a safer bet than giving adenosine. All right, so here's an example of antidromic where we get the wider complex. And to me, if you showed me this right away, even now I'd probably in my head goes initially to ventricular tachycardia. But it is a type of etiology with WPW that is more rare, and they can present like ventricular tachycardia. Here's the good news. If we gave this patient amiodarone, which is our treatment for stable ventricular tachycardia or ventricular tachycardia and cardiac arrest, we can still treat this rhythm with that and be okay. But we can also go, if the patient is unstable, all of the unstable tachycardias, whether they're wide or narrow, we go down the same pathway, and that is cardioversion. The thing we want to avoid giving to this patient is adenosine, because that can, again, lead to stimulus of the only basically cutting off the other pathway outside of the accessory pathway, and we can trigger the patient to go into a VFib arrest. All right, AFib. What is AFib? We've all heard of it. It's very common. AFib is basically where we have fibrillation of the atria and lots of different stimuli going on that are very unorganized, and there's no effective contraction of the atria. So a couple things that happen with AFib. So we can see here we get this squiggly baseline. There's no discernible P waves, and we have a narrow less than 120. And the R to R is variable. You can see the line I'm drawing is different lengths, right? So we call this irregularly irregular, narrow, with no discernible P waves. That is atrial fibrillation. If we compare that up here, we have P wave, P wave, P wave. We have a narrow QRS, narrow QRS. We have normal R to R interval. That is a sinus rhythm. Down here, narrow, no P waves, irregular R to R interval. This is atrial fibrillation, okay? And atrial fibrillation we call it ventricular response rate can vary. And so in AFib, that is with a normal rate, and the rates are going to bounce all over the place when we're looking at the monitor. That's another indication that they're in AFib that can cue you into that. But if the rates are generally within normal range, that could be a controlled rate or normal rate, a normal ventricular response. But when that ventricular response gets fast, and when true AFib with RVR tends to be very fast, basically what means is a lot of these little fibrillatory pacemaking stimuli from the atria are making its way down to the ventricles, and it creates a very fast rhythm. It can oftentimes look like those AVNRTs that we talked about. It can be associated with that WPW, which could be very serious if we don't want to mistreat that rhythm. It could be associated with a compensatory rhythm. It could also be associated with just normal variance in aging. And again, fluid overloading, stress, these can all trigger atrial fibrillation. And AFib happens at many different ages. We often associate it with geriatric patients, but young people can end up having AFib as well. So some complications with AFib is one big one is, remember, the atrial contraction gives us what's called that atrial kick. So if I have my atria and then my ventricle, right? And here's, let's say, my mitral valve. That atrial kick gives me the last 20% of the ventricular filling. I lose 20% of my ventricular filling when I have AFib because I've lost that atrial kick. So my ventricles still fill during the passive parts of the ventricular diastole, but that little kick I get right before ventricular systole goes away. So we're going to have problems maintaining cardiac output in high states of stress or cardiac demand or metabolic demand. And this can also lead to pooling of blood in the ventricles, in the atria. And this pooling of blood and that quivering can trigger the coagulation cascade and create lots of little thrombi. And those thrombi make their way into the ventricles and out the aorta, and it can lead to a stroke because they travel right up to the carotid arteries and into the middle cerebral artery. And as we get into neuro, we're going to talk about strokes, and the leading cause of occlusive CVAs is AFib because AFib leads to these little clots, and then that ends up in the middle cerebral artery, and that ends up with a large vessel stroke. And so that's why what we call MCA strokes are the most common, and the most common etiology are patients with uncontrolled or untreated AFib. So patients that have chronic AFib generally are on some type of anticoagulant. Patients that are like newly onset AFib probably aren't on some kind of anticoagulant. And this can be paroxysmal, meaning like it can come and go. Patients can be on controlled medication where they can go back into a sinus rhythm, usually by taking beta blockers or certain medications to help control their AFib. We've talked about like some of the causes like fluid overload, but valve disease, hypertension, acute infections, electrolyte imbalances, particularly low potassium and low magnesium, thyrotoxicosis, this is thyroid storm, can cause AFib. Drugs like sympathomimetics, alcohol is a big cause factor of AFib, pulmonary embolus, pericardial disease, acid-base disturbance, pre-excitation syndromes. These are like what we call WPW, cardiomyopathies, where we have dilated heart muscle. Or anytime we're stretching the heart muscle, that's going to cause irritability of those cells. or adrenal tumors can also cause it. So generally, we classify things into like a first episode or initial detection of AFib, regardless of duration. That's like a first episode. Recurrent AFib is when we have more than 2 episodes of atrial fibrillation that we've caught. Paroxysmal could be self-terminating episodes that last less than 7 days. And then persistent AFib, it doesn't terminate and it lasts longer than 7 days. And then long-standing persistent AFib lasts longer than 1 year. Anytime we're in these longer lasting, we are running the risk of stroke significantly goes up. And then permanent AFib is where basically unsuccessful treatments and we have AFib over a year. And then paroxysmal AFib greater than 48 hours in duration is unlikely to spontaneous convert back to a rhythm. And we basically, anytime we've had AFib for greater than 48 hours, giving an anticoagulant to that patient is part of the treatment plan. So their AFib has a lot of different classifications. We can look at some of the different ways that these focal activations of atrial dysrhythmias can happen. And so we have focal activation. Basically, we get all sorts coming from one origin, but then stimulating different parts of the atria, causing fibrillation. And then we can have multiple stimuli that's just causing different parts. And so this is not super critical for you to know, but it just shows sort of the patterns that can happen in AFib. So here's a perfect example of AFib. So if we look at this rhythm, do you see any uniform or discernible P waves? So there's lots of shaky baseline that you might start calling a wave, but there's nothing that's consistent, nothing that's even remotely regular. Then let's look at, is it wide or narrow, and is it wide or narrow, and is it fast or slow? So we have ventricular rates ranging from 150 to roughly, 75 beats per minute. So it's sort of all over the place. So this is not an AFib RVR necessarily. We'll show you what AFib RVR looks like. But this is also the last step is, what does my R to R look like? It's less than 120. My QRS is less than 120, right? And my R to R is irregular. So no P waves, narrow, and irregularly irregular. This is AFib. So management of AFib is, to try to treat the underlying cause, right? If they're fluid overloaded because of kidney failure or something like that, or heart CHF, we need to give some diuretics. We can treat with beta blockers or calcium channel blockers and anticoagulation. In the field, our thought process is we're going to go down the narrow complex tachycardia, stable or unstable, right? And remember, unstable, we want to rule out the causes of a compensatory rhythm before we go into our treatment. And AFib with RVR, this is where we generally intervene in the emergency setting with AFib. Most AFib rhythms that we see are incidental, and we're like, cool, the patient's in AFib. Hope they're on anticoagulants. Do they have a history of it? Is there anything that could be causing this? Those are kind of questions we're going to ask. But AFib, like I've said, that's controlled, like rates controlled, rarely requires any acute management. But AFib with rapid ventricular response, now we can see this ventricular rates can be very high, anywhere from 150, 180, 220, 280. It can be very fast, and these patients can become unstable. And so if you see an irregular rhythm that looks like this, it's irregularly irregular, it doesn't have any discernible P waves, it's narrow, it's not, it does not appear to have any sort of pre-excitation or WPW like appearance to it. I don't see delta waves. I don't see a widened QRS. So it looks like regular old AFib with a rapid ventricular response. Now, again, always ask yourself, is there an underlying infection? Is there an underlying hypovolemia that's triggered this? If so, then I'm going to treat that underlying cause. If not, if this is like a new onset AFib RVR and the patient is stable or unstable, then that will tell us what we do. So first, underlying cause consideration. Then understand a majority of these can be explained by something. But if it's like new onset AFib RVR or the patient is on anticoagulants, then we need to ask ourselves, is it stable or unstable? If stable, let's support them, give IV fluids, oxygen. We could consider a calcium channel blocker, okay, or beta blocker. And if your service doesn't carry those, that's okay. But in here, we're going to consider those treatments. And a lot of services carry verapamil or diltiazem. If they're unstable, it's new onset or anticoagulated patients, meaning they're on some sort of anticoagulant, we can consider cardioversion for these patients. If the patient is not anticoagulated and they've been in AFib for longer than 48 hours, we need to be careful with cardioversion because we could increase the risk of stroke by causing those clots that have formed to get shot out into the aorta and up in the carotid arteries. So we want to be cautious. But if the patient is truly an AFib RVR and they're very unstable, we got to treat the rhythm. But ideally, it's either new onset or they're anticoagulated to make them a good candidate for cardioversion. If they're not a cardioversion candidate, or we could still consider that pharmacological intervention in those patients. But giving a calcium channel blocker to a hypotensive patient, we have to do with caution. Okay, so AFib with that WPW, this is going back to what we were talking about earlier, that 20% of those WPW patients will develop AFib. And if they end up with AFib with RVR, they can deteriorate into ventricular dysrhythmias that are fatal, polymorphic V-tach and ventricular fibrillation. And VFib is an immediate cardiac arrest. So we really need to be careful, and we want to avoid in these patients some of the treatments that we commonly use, which are going to be adenosine and beta blockers and calcium channel blockers. And these patients need cardioversion and they need vagal maneuvers, or we can also use amiodarone to treat these patients. So that's going to be like your kind of wider complex, ugly looking AFib patients with RVR, or patients that have a history of WPW. We should prioritize the cardioversion side of that, or give them some amiodarone, which is kind of outside of most of the algorithms that we're going to learn for ACLS, but important to understand that distinction so we don't put somebody into cardiac arrest. All right, so what do you see here? I see an irregular narrow rhythm that's fast. It's not significantly fast, but it's pretty fast. In fact, actually, very fast, but I see irregular R to Rs. I don't see any regular P waves that are discernible. It doesn't have any appearance like AVNRT, where I have very consistent R to Rs with like retrograde P waves, and I'm seeing that classic irregularity. This is that AFib with RVR. Okay, A flutter now is a little different than AFib. So A flutter is a form of supraventricular tachycardia. It's caused by a re-entry circuit within that right atrium. And the length of that re-entry circuit kind of corresponds to the size of the right atrium, resulting in that like pretty predictable, what we call atrial rate. And we're going to learn what that means here in a second, because I understand that probably is a little confusing without the pictures. Ventricular rate is going to be determined by how fast those flutter waves, or how many of those flutter waves are going to get down to the ventricles. And so I'll draw this out. And so with the ventricular or atrial flutter, what we get are this flutter pattern in the atrial beats, and then we'll have a ventricular beat. Flutter, 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 ventricular beat. And there's a very predictable, consistent pattern. Most common is 2-to-1. So 2 flutters and then a ventricular beat. 2 flutters, ventricular beat. 2 flutters, ventricular beat. Okay. Sometimes higher degree blocks can occur, and it can with medications underlying heart disease and cause in lower ventricular rates, where we get 3-to-1 or 4-to-1 rates, where we start to see more flutter waves, and these rates can become very fast. And in true A flutter with what we call a 1-to-1 conduction, this can be really hard to determine because it has this like one little flutter wave. We can see incredibly fast rates like 300 beats per minute. And these patients definitely need cardioversion. And so this can be really triggered with WPW patients. When we've given them adenosine, this can happen. And we can end up with 1-to-1 conduction A flutter, which again, one of the complications of giving those WPW patients adenosine. In addition to those other fatal dysrhythmias that can occur. And we can see these patients rapidly need cardioversion to get them out of this rhythm. And the A flutter with 1-to-1 conduction, again, usually it progresses rapidly to VFib and they go into a VFib arrest. So let's look at A flutter here. So here is A flutter. And A flutter, this is doesn't even look like A flutter to me. All right, this is a better example. Here we go, A flutter. So here we have a 3-to-1 block, and we have 3 what appears to be flutter waves for every ventricular beat. And you can see they have a sawtooth appearance. And that's flutter waves are large, much larger than a P wave, and they have this sort of backwards sawtooth that looks almost like if you looked at a saw blade up close. And so when you see A flutter, that's how you're going to notice it. And if it's a 1-to-1 conduction, you'll have basically 1 flutter wave for each QRS with a very, very fast ventricular rate. And it's important to count the ventricular rate in A flutter, because if they have like a 4-to-1 AV block with the flutter wave to the ventricular beat, you could actually have what looks like a fast atrial rate, but a very slow ventricular rate. And they can actually end up in, with low blood pressure and things like that from the slow ventricular rate. Here's what that 1-to-1 conduction A flutter looks like. So we can see the reverse sawtooth pattern here to each P wave, and so or each QRS complex, and really tough to tell the difference between this and AV NRT. If you gave this patient adenosine, would they die? No, but it could have been triggered by adenosine from giving a WPW patient adenosine. But these patients generally with 1-to-1 A flutter are going to decompensate pretty quickly. So we need to generally go down that unstable narrow complex tachycardia pathway, and that's going to lead us right to cardioversion. All right, some pearls. Suspect atrial flutter, which the most common type is that 2-to-1 block wherever there's a regular narrow complex tachycardia at 150 beats per minute. Generally, the rates are very predictable, right? Like 2-to-1 is 150 beats per minute. 1-to-1 is 300 beats per minute, and so on. So anytime you see a very consistent beat at 150 beats per minute, think A flutter. In contrast, like when we talked about sinus tachycardias, the rate can vary slightly. And AV NRTs and AVRTs, we usually see rates of like 170 to 250. If I go back to this 12 lead, if you count this out, it's almost exactly 300 beats per minute because it's one box. So very consistent, 300 beats per minute. I would think 1-to-1 A flutter. All right. To differentiate between these rhythms, we can try some vagal maneuvers. We can test dose adenosine. In most of those patients, AV NRT will revert to a sinus rhythm, where sometimes the slowing of the ventricular rate can unmask the underlying atrial rhythm. And if it's sinus tachycardia or atrial flutter, we sometimes can see that. So we can try that. So here is an A flutter 5 5-to-1 conduction. It's quite a bit. And then you can see the upper was when the patient was in a more 1-to-1 conduction, and we treated with some adenosine. You can see the adenosine slowed down the ventricular rate, and then you can definitely see the A flutter underlying. All right. If the patient is in 1-to-1 conduction at that consistent 300 beat per minute, immediate cardioversion. Stable AFib with treat with diltiazem unless we suspect WPW, then that would be a bad drug to give. Adenosine and vagal maneuvers will not convert A flutter, so they will stay in A flutter. So A flutter patients that are in A flutter are not going to convert with those treatments. But again, sometimes if we slow down that, are able to temporarily slow down the ventricular rate, we can see those flutter waves. Amiodarone can be used for AFib, A flutter. It can be prescribed orally. Not common practice in the emergency setting, but it is in your back pocket. It is within your scope of practice. It is something you can consider, sort of as an off-label use if you do suspect a true A flutter or AFib RVR, and you're concerned about WPW. Amiodarone is a great medication to give in those cases. All right, AV nodal blocks. This is one that all students love because it's all over every test, and so it's one that we're going to spend some good amount of time on. All right, it's the first type of AV nodal block, and when I say AV nodal block, it's a blockade of the AV node, and there's different types of blocks. And essentially, if you think about like a block is like a road that's closed, and a road can be closed completely and no cars are getting through, right? Or a road can be closed where they let one car through at a time and there's a big significant delay, or they could let maybe 2 cars in at a time or 3 cars in at a time. And those are all going to be how we sort of describe AV blocks. So the first block we talk about is a first degree AV block. And first degree AV blocks are when the PR interval is greater than 200 milliseconds. And so when that PR interval is greater than 4 boxes, well, now we are running into potentially a first degree block. So first degree blocks can be rarely like in themselves symptomatic or cause significant hemodynamic collapse, but it's the underlying cause that should be considered. It could be caused by mitral valve surgeries. It could be caused by inferior MIs. It could also be caused by electrolyte disturbances, but myocarditis is another potential cause, or potentially the patient has taken AV nodal blocking drugs like beta blockers or any of these other types of drugs, like especially digoxin, which is not as common anymore, but calcium channel blockers can cause that. It could also just be normal for the patient. So longer PR interval, but consistent P waves, still regular, no irregularity, no dropped complexes. This is going to be a first degree AV block. Here's an example of that on a 12 lead. We're seeing a elongated PR interval. It's a little over 1 big box. So that's significant, right? And so that is a first degree AV block. And the rate is slow. So all these AV blocks are causes of bradycardia. Generally, progressively, the more advanced or higher degree block we get, the more hemodynamic compromise comes from the rhythm itself. Okay, the next type of AV block is called a second degree AV block, and there's 2 types of second degree AV blocks. We're going to talk about type 1, or it's also referred to as a Mobitz 1. Or something called a Winky-Bach, which is a weird name. But second degree type 1 is an appropriate term for it. And essentially, it's like a first degree heart block, except instead of just a consistent PR interval that's elongated, we're going to see a PR interval that gets consistently longer and longer and longer until it disassociates and we drop a QRS complex. So it's longer, longer, longer drop, longer, longer, longer drop. And in that dropped portion, we'll see a P wave with no QRS complex afterwards. And you can see here the PR interval is progressively elongating, and then we have the dropped QRS complex. And it's also, you can see it as it gets closer here to the T wave, then we drop. So the PR interval basically gets longest right before the drop beat.